Hello, everyone. This is Dr. Mickey recording a lecture on Chapter 33, which is drugs and medications for inflammation and fever. So the chapter begins with the lines with human defense mechanisms, and this chapter goes over the inflammation and acute and chronic, and the infections and the immune system and the different types of immune deficiencies. So this slide is provides the um, an explanation of what is the inflammation, what is the defense mechanisms, where's the immune system connects with the inflammation and infection, and the if we look at the three steps or the line of defense, we will find that the first line of defense is the innate resistance. Either it's like physical and mechanical barriers or biochemical barriers. And I have different examples of both types of first line of defense in terms of physical and biochemical barriers. Like physical, the epithelial cells of the skin sloughing off of cells, epithelial membranes lining in the GI and genitourinary and respiratory systems, coughing, sneezing, vomiting, voiding. All of these are mechanisms of the physical and mechanical type as barriers which constitute the first line of defense mechanisms. And other examples of the biochemical barriers, which lies under the first line of defense as well. So this is the first line of defense. But what is the second line of defense, which is inflammation, inflammatory process? And we'll go over both different phases or steps of the inflammatory process and the pathophysiology, which entails the inflammation and the inflammatory process. And then the third line of defense, which is the adaptive immunity, which is the immune system, the immune response. When the immune response is elicited, that is the constitute or considered as the third line of defense. So we said that the first line of defense, which includes the physical and mechanical barriers and the biochemical barriers. An example of the biochemical barriers would be the normal flora or normal bacterial flora in the GI tract or in the skin surfaces, or the bacterium lactobacillus, which is the normal vaginal flora, or sebaceous skin gland secretions, which would secrete lactic acid and fatty acids to kill bacteria and fungal or fungi. Other epithelial cells will secrete antimicrobial peptides. All of these are different forms of biochemical barriers, which lies under the first line of defense. Now, the second line of defense, which is the inflammation and the inflammatory process, so the inflammatory process, which is a major reactive defense mechanism. It's natural, non-specific defense mechanism. What would cause the inflammation, or what would be the etiological factors for inflammations, can be caused by mechanical damage like trauma, infections, ischemic changes, or decreased perfusion and ischemia, deprivation of nutrients like nutrient deprivation, malnutrition, changes in temperature, radiation, allergens, patients who are allergic to certain types of environmental or substances that will elicit the inflammatory process and inflammation. The mast cells activation result in the synthesis or degradation of the chemical mediators. So the right side of the slide shows that this is the hallmark of the inflammatory process. And inflammation results in secretions of prostaglandins, leukotrienes, neutrophil or eosinophil chemotactic factors, result in the secretions or release of the histamine, which will elicit all these or result in all these symptoms of the allergic reaction or inflammatory reaction or response. So the inflammatory process begins with the activation and the mast cells will be activated to release all these chemical mediators, either by synthesizing them or by being degraded, like degradation of the mast cells to release all these chemical mediators in the bloodstream. So, and these chemical mediators, again, they include histamine, eosinophil chemotactic factors, neutrophil chemotactic factors, prostaglandins, leukotrienes. So an example would, about the inflammatory process would be the an IgE mediated destruction of parasite, in which that the mast cells will be, so the parasite, first of all, the parasite is an antigen. So the parasite in the GI tract is going to be an antigen, which will, and that antigen would be released, and then it will activate the beta cells, which is the B lymphocyte cells, which is the integral part of the immune system. So we have beta cells and we have the B cells and T cells. So the B lymphocyte and T lymphocyte. This one is the B lymphocyte or B cells, which in which the B cells are, they have the ability to produce the immunoglobulins, the antibodies. So when the parasite activate the B cells or the B lymphocytes, they will produce the immunoglobulin type E, IgE, antibodies type E. These immunoglobulin type E are going to attach to the mast cells, which will be activated, and that activation of the mast cells is going to release these chemical mediators, including the ECF and the NCF. When we said that the NCF in this case, the parasite is going to activate the B cells attach the mast cells, the mast cells will be activated to release the ECF only, which is the eosinophil chemotactic factors. What's the function of this ECF, eosinophil chemotactic factors, which has been released from the mast cells that are going to get all these eosinophil cells from the bloodstream down to the GI tract to where the parasite is present to attack the parasite, which will elicit the inflammatory process. That's the inflammation or inflammatory process, which included here in this case the immunologic response as well. So the last two steps, 5 and 6, in which that the ECF, eosinophil chemotactic factors, they will attract the eosinophils from the circulation, get them from the bloodstream into the GI tract. So then these eosinophil cells, which is part of the white blood cells, they will get to the surfaces of these porocyte and will release the potent lysosomal enzymes to damage these porocyte microorganisms. So this is an example. The porocyte, whenever you say porocyte, means the IgE immunoglobulins will be produced to attack the porocyte. So patients with the porocyte infection, we anticipate that in their blood lab values, you will find, or CBC and differential CBC, you'll find that the eosinophil count will be extremely high in response to the presence of the porocyte infection or porocyte microorganisms. So the benefits of inflammation: limit and control the inflammatory process, make it contained, not to distribute to and invade other places in our organs, prevent and limit infection and further damage. Through the influx of fluid to dilute toxins produced by bacterial protein systems, and protein systems which include the complement and clotting factors and white blood cells like neutrophils, macrophages. Initiate the adaptive immune response. So the inflammatory process, it will elicit the immune response and immune reaction to produce B cells and T cells and antibodies or immunoglobulins. And initiate healing. Inflammatory process, the acute inflammation, it includes or has two stages or phases. The first one is the vascular, and then the second one is the cellular. Now, the vascular, in which that the movement of plasma into the interstitial space will result or lead to edema. That explains why patients with the inflammatory process includes edema and swelling of the affected part or site. So the microscopic changes occur in seconds. Like there will be from these, the vascular changes will include vasodilatation, increased vascular permeability, adherence of the white blood cells to the inner wall of the blood vessels. So the resultant effect of the increased vascular permeability, it will lead to edema, warmth, hotness, and redness. So the affected site or part will become red, warm, and swollen in response to the increased vascular permeability. And the second phase or stage or step in the inflammatory process, which is cellular, in which that the inflammatory cells will release the chemical mediators like histamine, bradykinin, and these histamine and bradykinin as the chemical mediators will increase capillary permeability, in which that the white blood cells and platelets will move towards the damaged cells, and phagocytosis will begin. And these chemical mediators include the histamine, serotonin, kinins, which is like bradykinin, complement components, chronic system, prostaglandins and leukotrienes, and cytokines. Now, the mast cells, which is cellular bags or granules located in the loose connective tissue, close to the bloodstream. They're very close to the bloodstream, usually located. They're located in the skin, digestive lining, the GI tract, respiratory tract. The basophils, which is a differential or sub type of white blood cells, basophils, in the blood, they function in the same way as tissue mast cells. So the basophils will function like as if they are mast cells. So the stimuli activates the mast cells to release its potent soluble inducers of inflammation, such as we said, histamine, bradykinin, cytokines, prostaglandin, leukotrienes. All these are type of chemical mediators or soluble inducers of inflammation. So either that the mast is going to synthesize the new production and release of these chemical mediators, or through the what is called the degradation of the mast cells. Then it will release all this granule content in the area. So either the mast cells is going to release these chemical mediators through the degradation of the mast cell or through the synthesis and production of these chemical mediators. So, for example, the histamine, one of the main components of the chemical mediators when the mast cell has been activated, and that will result through the degradation of the mast cells. So it's a vasoactive amine that will lead to rapid constriction of the large blood vessels. And it has also other effects on the venules, like it will lead to also dilatation of the post-capillary venules. But on the large blood vessels, it will cause vasoconstriction. Also, it will increase the vascular capillary permeability, resulting from retraction of endothelial cells lining. Also, it increases the adherence of leukocytes, which like white blood cells will attach to the endothelium, makes the white blood cells stick to the endothelium. So that's from the histamine, increases adherence of leukocytes to the endothelium. The histamine, it's one of the major or integral types of chemical mediators in the inflammation. So it's a key chemical mediator in inflammation. Stored in mast cells. Once the inflammatory process is elicited, the histamine will be released through the degradation of the mast cells. So the histamine there are two different types of histamine receptors. So before we get to the different types of chemical receptor of histamine receptors, the release of the histamine will produce vasodilatation. So the histamine, again, in the previous slide, we said that histamine will produce temporary rapid constriction of large blood vessels and dilatation of the post-capillary venules. So for the capillaries, it will result in a vasodilatation, making capillaries become leaky, which will lead to tissue swelling and edema. So the histamine is responsible for symptoms of the anaphylaxis. And we'll get to symptoms or manifestations of anaphylaxis during, as we know, we'll discuss this chapter. So the histamine affects cells by binding to either the histamine receptor type 1 or histamine receptor type 2. Because there are two different receptors that are affected by the histamine on the target cell's surface. So the first one is called pro-inflammatory receptors, H1 receptors, and the other one is called H2 receptors, which is the anti-inflammatory. So pro-inflammatory H1 receptor, which can be found in vascular smooth muscle in the bronchi, respiratory system, and on the sensory nerves. So stimulation results in the itching, pain, edema, vasodilatation, bronchoconstriction, and it results in a characteristic of the inflammation, the allergy. So patients are allergic who develop the allergic reaction. That's because of the H1 receptor, histamine type 1 receptor, which is a pro-inflammatory, has been activated, has been stimulated, which will result in all the symptoms of the allergic reaction, like itching, pain, edema, vasodilatation, bronchoconstriction. However, the anti-inflammatory, which is type 2, histamine receptor, H2 receptor, which is located now, H2 is located in the parietal cells of the stomach mucosa. So it's in the GI tract and the parietal cells of the stomach mucosa. So stimulation of the H1 receptor in the GI tract results in secretion of gastric acid, in other words, hydrochloric acid, HCl. So H1 receptor in the lungs and bronchial or bronchi, smooth muscle of the blood vessels and sensory nerves, H2 receptors in the stomach. So that's about histamine and ECF and NCF as a chemical mediators will result from the degradation of the mast cells. However, the mast cell synthesis, mast cells are able to synthesize chemical mediators like leukotrienes, prostaglandins, and platelet activating factor. So the chemical factors like neutrophil chemotaxis factor, NCF, or eosinophil chemotaxis factor, which is ECF. The NCF attracts neutrophils, and the ECF attracts eosinophils. Leukotrienes, product of the arachidonic acid, and this arachidonic acid from the mast cell membrane. Also, it's a sulfur-containing lipids that will produce histamine-like effects. Leukotrienes are like sulfur-containing lipids that will produce histamine-like effects, very similar to the histamine. Vasodilatation, capillaries, and edema, swelling, pain, warmth, erythema. And the smooth muscle contraction and increased vascular permeability. The prostaglandins are similar, they have similar effects to the leukotrienes, but they also will induce pain sensation. Now, the NSAIDs, they block the synthesis of prostaglandin type E series, which here the importance of the NSAIDs and prostaglandins is that the NSAIDs, once they block the synthesis of prostaglandin type E and prostaglandin type E series or prostaglandin in the GI tract, it's kind of protective mechanism for the GI. So the NSAID, they destroy or stop the synthesis of the prostaglandin that will make the patient at risk for, or individual at risk for, the ulcerations and GI problems. Mast cells under production of the chemical mediators, either through the synthesis or degradation. The protein system also is a form of mast cell synthesis. We have complement system, coagulation system, kinase system, and all contain active enzymes, which is like proenzymes, sequential activated. And the complement system, it can destroy pathogens directly, the complement system. And it can activate or collaborate with every other component of the inflammatory process or response. And there are different pathways of how the complement system would destroy the pathogen directly. Coagulation clotting system, coagulation or clotting system, it forms the fibrinous meshwork at an injured or inflamed site. Fibrinous meshworks like the blood clots. So it prevents the spread of the infection. It will keep the microorganism and foreign bodies at the site of the greatest inflammatory cell activity. It forms a clot that stops the bleeding. And it will provide a framework for repair and healing. And the main substance is that insoluble protein, which is the fibrin. Now, the kinase system functions to activate and assist the inflammatory cells. And the primary kinin is the bradykinin. And the bradykinin, it causes dilatation of blood vessels, merely to result in pain sensation, smooth muscle contraction, vascular permeability. So the table provides different descriptions of the chemical mediators, or description for each of the chemical mediators like bradykinin, complement, C-reactive protein, cytokines, histamine, leukotrienes, and prostaglandins. Now, the phagocytosis, which is a process by which the cell ingests and dispose the foreign material, and it also includes the production of adhesion molecules. Part of phagocytosis includes demargination or pavementing, in which the leukocyte cells adhere to the endothelial cells of the blood vessels. And then the diabetes, which is the immigration of these cells through the endothelial junctions. So we can include some steps for the phagocytosis, like the adherence, engulfment, and then destruction of the target. Phagocytosis, neutrophils. Also, we refer to the neutrophils as the polymorphonuclear neutrophils, PMNs. They're the predominant type of cells that will be involved in early inflammatory responses. And that's the first leukocyte, white blood cell, to arrive to the affected area. It would inject, ingest the, engulf the bacteria and destroy bacteria. It will ingest also dead cells and cell debris. The cells are short-lived. And may become a component of the purulent exudate. And when we say purulent exudate, means pussy drainage. Monocyte and macrophages. The monocytes are produced in the bone marrow, then they will enter the circulation and migrate to the inflammatory site, where they develop into macrophages. These are the monocytes, because they're produced in the bone marrow. They will enter circulation and then migrate to the inflammatory site, where they will develop or become macrophages. The macrophages, however, typically they arrive at the inflammatory site about 24 hours after neutrophils. Eosinophils, which will be in large quantities during the allergic reaction or parasite infection. There will be also in large quantities during the parasite infections. So the eosinophils, they release chemicals that act to control the effects of histamine and serotonin. And basophils, they carry the histamine and heparin in their granules, and they are released during the inflammatory response. NK cells, or natural killer cells. Function is to recognize and eliminate cells which became or has been infected with either viruses or mostly viruses. So virally infected cells will be recognized by the natural killer cells. also the natural killer cells, the NK cells, their main function is to recognize and eliminate the virally infected cells. Also, in addition to this, also is very effective to eliminate cancer cells. Recognize cancer cells and eliminate and destroy them. The platelets produced primarily by macrophages. I'm sorry, the platelets, they are will be activated, and the activation of these platelets will lead to the degradation and degranulation and interaction with components of the coagulation system. Interleukins, like interleukin 1 or 6 or 10, there are different types of interleukins. The IL-1 or IL-6 or IL-10, they're produced primarily by macrophages and lymphocytes, which will be producing these interleukins in response to the pathogen or stimulation by other products of the inflammation. So the presence of these pathogens will stimulate the production of the interleukins by the macrophages and lymphocytes. Interleukin, so the different types of interleukins, the interleukin type 1 or IL-1, which is pro-inflammatory cytokine. So all of these are cytokines, either it's NK cells, platelets, or interleukins or interferons. They are cytokines, chemical mediators released from the mast cells. So the IL interleukin type 1 it is endogenous pyrogene. And when we say pyrogene, means the substance or chemical is going to elicit the fever. So IL-1, it's a fever-causing cytokine. IL-6, it directly induces hepatocytes to produce many of the proteins which are needed for during the inflammation. That's IL-6. They are directly inducing the hepatocytes, the liver cells, to produce many of the proteins that are required or needed during the inflammation. The IL-10, they are anti-inflammatory cytokine. So IL-1, it's pro-inflammatory cytokine. IL-10, anti-inflammatory cytokine. And they are produced to downregulate both inflammation and acquired immune responses. That's IL-10. However, the interferons, they protect against the viral infections, and these interferons are the best antiviral medications, or most effective medications for viral infections, produced and released by virally infected host cells in response to viral double-stranded RNA. So we have two different types. We have INF alpha and IFN alpha and IFN beta. And we have also IFN gamma. So IFN alpha and IFN beta, they induce production of antiviral proteins. IFN gamma, they increase the microcidal activity of the macrophages. So we have two different types of IFNs, or three different types of IFNs. Interferon, IFN, alpha, beta, and gamma. Alpha and beta, they induce production of antiviral proteins, and gamma, IFN gamma, they increase the microcidal activity of macrophages. The tumor necrosis factor, TNF, tumor necrosis factor alpha, TNF alpha, or A, which is usually secreted by the macrophages in response to recognition of foreign materials. So what is the effect or the systemic effect of secreting the large amount of TNF factor? It will induce fever by acting as an endogenous pyrogene. It will increase the synthesis of the inflammatory serum proteins by the liver, and it will cause or result in a wasting syndrome, something called cachexia, severe loss of the muscle mass and weight, and patient becomes cachectic, extremely having like thin bone and skin and bone, very underweight, and in terms of that, that's a wasting syndrome. And cachexia, it's spelled out as the CACHEXIA. When we see patient is becoming like cachectic, means patient has lost a lot of weight, significant amount of muscle mass has been lost, and patient was extremely reduced to become like patient is becoming like a skin and bone. Clinical manifestations of the inflammation. So it includes redness, heat, pain, swelling, loss of function. The exudate fluids or exudative fluids. Exudative fluids include fibrinous exudate or fibrin, fibrinous exudate, which is thick clotted exudate, which would indicate more advanced inflammatory process or more advanced inflammation. When there's the fibrinous exudate. When there is a purulent exudate, which is more pussy, it indicates a bacterial infection. And it's the characteristic of a walled-off lesions, like a cyst or abscess. Hemorrhage exudate. Exudate contains blood, which indicates bleeding or hemorrhage. Fluid in tissue spaces, which is edema, and that's due to increased pressure in the vessels, which is the hydrostatic pressure. Initially, it is composed of serous fluid, which is transudate, and later will contain plasma proteins, primarily albumin, in which that the protein exert oncotic colloidal pressure that will further draw fluid from blood vessels, which result in exudates. So as the plasma protein fibrinogen leaves the blood, it is activated to fibrin by products of the injured cells, in which the fibrin strengthens the blood clot formed by the platelets. So there are some functions of the transudates and exudates in which that these transudates and exudates, they will dilute the toxins from dead cells. They will also prevent additional injury because of pain, a limited use due to pain. They will prevent additional injury. And other functions of the transdates and the exudates is to clear the blood cells and proteins to the site, in other words, the antibodies. It also will carry toxins and waste products from the site, and mostly will be through the lymphatic system. In addition to all of this, that the main function of the transdates and exudates that it will dilute toxins from dead cells. The manifestations or local manifestations and signs and symptoms of the inflammation, it includes redness, heat, pain, swelling, loss of function. And I have also indicated here or included in the slide the cause for each of these manifestations, like why the reason for for the inflammatory site or the site of inflammation becomes red, and that's because of hyperemia from the vasodilatation, which has resulted from the chemotactic factors like the histamine and other chemical mediators. The systemic responses, it will include fever, leukocytosis, which is the increased white blood cell production, in which a phenomena called left shift phenomena or shift to the left phenomena, malaise, nausea, anorexia, increased like tachycardia, increased heart rate, and tachypnea, increased respiratory rate. This slide explains pretty much what we have just discussed earlier about the injury to the cell or cell injury result in the mast cell degradation or synthesis of and the release of chemical mediators like histamine, bradykinins, the complement system, and the leukotrienes and others, and cytokines, and what each of these chemical mediators will result in a specific manifestation, like the first one at the top, the vasodilatation. The effect of these chemical mediators, mostly the histamine and bradykinins, the leukotrienes and others, they will lead to the vasodilatation, and that's why the the inflammatory site will inflamed site will be swollen, and there is a redness and heat, and that's from the vasodilatation. And because of the vascular permeability, inflamed site will become edematous and swollen. And because of the cellular infiltration, sometimes there is a pus. Mostly that's when there is an infection. In addition to also thrombosis will result in clot formation, and pain is going to be or resulted from the stimulation of the nerve endings by these chemical mediators. The systemic responses to the inflammation includes the fever, which is usually caused by exogenous and endogenous pyrogens. So anytime you hear pyrogens, means it's a substance or molecule or microorganism or its toxins that is going to elicit the fever response or fever and elevated temperature. The core body temperature will be elevated. So it acts directly on the hypothalamus. When the set point of the hypothalamus set point will change in response to these pyrogens, and then patient will spike a fever. So leukocytosis, which is the increased white blood cell counts, number of circulating leukocytes, which will go up higher than 11,000. Fever, which is pyrexia, which is often, companies will be associated with inflammation and the inflammatory process or response. And it's usually associated also with infections. So the normal thermal regulation, in which that cells constantly produce heat by metabolism. The mechanism to lose heat, which is the dilatation of surface blood vessels, sweating, perspiration. These are mechanisms to lose heat. So the body temperature is set and controlled by the hypothalamus. These pyrogenes are going to change the set point at the hypothalamus and elevate the temperature. So with the infection, when there is an infection or the presence of toxins, that some bacteria, they will release the biochemical into the bloodstream, and that is called exogenous pyrogenes, which is lipopolysaccharides of gram-negative bacteria. So these are the toxins that are going to be released as the pyrogenes, in which that these will signal the white blood cell count to produce their own chemicals, which will, which is in this case, they are endogenous pyrogenes. So we have either exogenous, which is the bacteria, which will release biochemicals, or the white blood cell count, which will produce their own chemicals, which is the endogenous pyrogenes, which is like the interleukins, like interferons. These are endogenous pyrogenes. So both exogenous, either bacteria and its polysaccharides, or endogenous white blood cells in the interleukins or interferons, exogenous and endogenous pyrogenes, both will induce synthesis of prostaglandins. And this prostaglandin is going to change the set point or raise the set point at the hypothalamus. And that will result in a fever to spike. The inflammation is either an acute or chronic. And acute inflammation, these are the 5 steps for the inflammatory response or process to take place. So which will begin with vasodilatation. However, chronic inflammation, in which that the inflammation will last longer than 2 weeks, other causes of chronic inflammation would be in patients like with tuberculosis, pulmonary TB, in which there is a high lipid and wax content of a microorganism. Ability to survive inside the macrophages. Sometimes the microorganisms that are able to survive inside the macrophage, like in leprosy, syphilis, and brucellosis. Toxins or chemicals, particulate matter, or physical irritants, like the inhaled dust with splinters. So characteristics of chronic inflammation, dense inflammation of lymphocytes and macrophages. Dense infiltration, these lymphocytes and macrophages will infiltrate granuloma formation to isolate the infected area. And these granulomas, like in toxoplasmosis, in which that the granuloma, it will begin with some macrophage differentiate into epithelial cells, and other macrophages will differentiate into like giant cells. And these giant cells are, which are able to engulf very large particles. Non-steroidal anti-inflammatory drugs, NSAIDs, primary drugs for treatment of mild to moderate inflammation. The main agent or drug is the aspirin, acetylsalicylic acid, celecoxib, which is Celebrex, aspirin. The main side effects of aspirin is stomach pain, severe GI bleeding, metabolic acidosis, and we have different dosages of aspirin. The baby aspirin, which is a small dosage, 81 milligram, and we have also 325 milligram. Celecoxib, which is Celebrex, comes in 100 up to 400 milligrams BID. That's the dosage daily. The side effects, which is increased risk of the cardiovascular events, like unstable angina or acute myocardial infarction, and the acute kidney injury, AKI. The non-steroidal anti-inflammatory drugs, the NSAIDs, the acetaminophen, since the acetaminophen or tanolol has no anti-inflammatory action, so it is not actually shouldn't be like listed as an NSAID because it does not have an anti-inflammatory action. So the prototype drug for the NSAIDs is ibuprofen. So the ibuprofen, the common indications would include pain associated with chronic musculoskeletal disorders such as rheumatoid arthritis and osteoarthritis, headache, dental pain, dysmenorrhea. There are two different types of cyclooxygenase enzyme. We have a receptor and an enzyme. So the cyclooxygenase receptors COX-1 and we have COX-2. So the COX-1, in terms of that, there are certain medications that are going to inhibit the cyclooxygenase, either COX-1 or COX-2 or both. The cyclooxygenase, they are present in all tissues. COX-1 pretty much in all tissues, and it reduces the gastric acid secretion. It promotes renal blood flow to the kidneys, and it will promote the platelet aggregation. So the inhibition of the COX-1 one receptor, will result in bleeding, gastric upset, and reduced kidney function. However, the medications are going to block COX-2, cyclooxygenase 2, that will result in suppression of the inflammation. It will suppress the inflammatory process. So tissue damage that will result in a release of the arachidonic acid. So if we block the arachidonic acid before it becomes cyclooxygenase 1 and 2, or 2, that we can prevent the inflammation, and the inflammatory symptoms will subside. So we can treat that by blocking or inhibiting the arachidonic acid becoming a COX-1 or COX-2 or both. So the aspirin, it treats inflammation by inhibiting both COX-1 and COX-2. Overdose of the aspirin may lead to the salicylism, which is salicylate overdose or toxicity. And the salicylism, or the aspirin or salicylate toxicity or overdose, the symptoms of salicylism includes dizziness, headache, excessive perspiration, and tinnitus. So the salicylates or aspirin is an inexpensive, effective, first-generation non-steroidal anti-inflammatory drug. Very common among adults. Since its discovery, the aspirin has become one of the most highly used therapeutic drugs in the world. And the aspirin has the following indications, like it can be used as an analgesic. So for analgesia, it has the ability to relieve mild to moderate pain. It can be used as an anti-inflammatory drug because it has the ability to decrease mild or moderate inflammation. It can be also used as an antipyretic. It has the ability to lower the body temperature. It has the ability to be to suppress the platelet aggregation, so it can prevent or treat cardiovascular disease like myocardial infarction and stroke, because it has the ability to prevent blood clotting. So the aspirin blocks the synthesis of prostaglandins by inhibiting the enzyme cyclooxygenase. So the aspirin and the ibuprofen-like NSAIDs, they block both forms of the enzyme, which is the cyclooxygenase enzyme, known as COX-1 and COX-2, by changing their structures and preventing the formation of prostaglandins. So the adverse effects of salicylates, we said, and especially when there is salicylism, which is an overdose, we said the patient will have tinnitus, dizziness, headache, excessive perspiration. Patient also may develop angioedema, metabolic acidosis, GI bleeding, hepatotoxicity, hemolytic anemia. So the patient also may develop the ulcer formation, right? So the NSAID induced ulcer formation. So salicylates and other NSAIDs, they may lead to or result in ulceration or ulcer formation in the GI tract. So the COX converts the arachidonic acid to prostaglandins. So it'll be less acid, more mucus protection. In other words, that the COX enzyme, it's protective because it produces prostaglandins, and these prostaglandins are very, highly protective for the GI tract, especially the stomach, and prevent the stomach from the ulceration or from the effect of the hydrochloric acid. So it protects against the acidity. The prostaglandins protects against the acidity in the stomach. However, when these NSAIDs are going to inhibit the COX enzyme and prevent prostaglandin formation, then there will be more acid, less mucus, more mucus protection, and there's a direct irritation of mucosa, which leads to ulceration of the stomach. Other NSAIDs or non-steroidal anti-inflammatory drugs include ibuprofen and ibuprofen-like medications or agents. So the ibuprofen and similar non-NSAIDs, they are the most common drugs for treating mild to moderate pain and inflammation. Now, the NSAIDs have the following similarities in terms of that they're all similar, and in which that all of the NSAIDs, they have the same mechanism of action. They inhibit both COX-1 and COX-2. They all have analgesic properties. They are widely prescribed to treat patients with mild to moderate pain. They all have the anti-inflammatory properties, like most are specifically approved for osteoarthritis, other for rheumatoid arthritis. And they all have antipyretic features in which that they lower the temperature. Almost now, all of them are approved for this indication, which is antipyretic, which is to treat fever. Most are weak acids that are readily absorbed in the stomach. NSAIDs, we said they have a lot of similarities, that most of the NSAIDs are strongly bound to albumin in the blood. Most of these NSAIDs are metabolized in the liver. So they become inactive metabolites, which will be eventually are excreted by the kidneys. All of these, or all the NSAIDs, they have the ability to damage the GI mucosa, including bleeding and ulcer formation. Many of these NSAIDs, they are nephrotoxic at high doses. Many of these NSAIDs, they cause an increased risk of cardiac events, such as heart failure or acute myocardial infarction. So the cyclooxygenase inhibitors, COX-1 and COX-2, they are widely used to suppress the inflammation, relieve pain, reduce fever, but their side effects would include gastric ulceration, bleeding, and renal impairment. Systemic corticosteroids. These systemic corticosteroids are effective in treating severe inflammation. Naturally, these steroids are released as cortisol from the adrenal cortex. These steroids, they can suppress histamine and prostaglandin. Now, the serious adverse effects of steroids, first, suppression of the adrenal gland function. So that will result in an immunosuppression. So it will suppress the immune system. And decrease because there will be decreased steroid or cortisol production. Another effect of steroid, that steroid will result in hyperglycemia, mood changes, cataract, peptic ulcer disease, electrolyte imbalances, osteoporosis. These are some of the many side effects of steroid, but these are the most common and most important. So they suppress the immune system by changing or altering the quality of the lymphocytes, especially the T lymphocytes, which is the main cells and of the white blood cells or T lymphocytes responsible for the immune response. So suppression or changing the quality of these T cells will suppress the immune system. Cortisol, responsible for the metabolism of glucose, it will lead to hyperglycemia. So the steroids are used for short-term treatment of acute inflammation, patients with asthma, patients with chronic obstructive pulmonary disease, patients with autoimmune disease, patients with systemic lupus, erythematosus, and other diseases. So it can be used for short-term treatment of acute inflammation. Now, for long-term treatment, we can prescribe the drug for long-term, but we have to keep the doses as low as possible. We use alternate day dosing. And we anticipate that patient may develop the Cushing syndrome. And that's from the consistent elevation of steroid or receiving the steroid or corticosteroid on a daily basis. However, that at any time you would, just have, you decide to stop or discontinue the drug, then it has to be done gradually. Otherwise, we when the drug or the steroids are promptly or suddenly discontinued, then we anticipate that the adrenal glands may shut down. It may result in immune suppression, or what is called the adrenal insufficiency or adrenal shutdown, and that may result in permanent loss of the adrenal gland function to produce any steroid in the future. So to allow or to prevent this from happening, which is the adrenal insufficiency, or what is called the Edison's disease, or the adrenal gland shutdown, we will discontinue, taper off the steroid, and gradually discontinuing the steroids. So prednisone is the prototype for steroids or corticosteroid. There are different forms of the corticosteroid. We have the betamethasone, cortisone, dexamethasone, hydrocortisone, methylprednisolone. Acetaminophen, which is Tylenol, which is administered for pain relief and to reduce fever, but it has no anti-inflammatory properties, as we said. So the acetaminophen Tylenol is a non-opioid analgesic. Also, it will lower the temperature, so it's classified as an antipyretic as well. Antipyretic. Some of the side effects of Tylenol is the hepatotoxic. So hepatotoxicity may result from the acetaminophen, so with overdose, or may result in patients with liver failure. That hepatotoxicity, either it will result from the overdose or in patients with liver failure. So the hepatic or liver failure, so some of the manifestations of the liver failures like coma, encephalopathy, the bleeding tendency, and the early symptoms would be like nausea, vomiting, diarrhea, sweating, abdominal pain. How would we treat the overdose when a patient develops a Tylenol toxicity or overdose? It will be treated with acetylcysteine mucomist, and acetylcysteine or mucomist. So the acetaminophen overdose is treated with oral or IV acetylcysteine mucomist. So for maximum effectiveness, the antidote should be administered within 8 hours of acetaminophen ingestion. It should be administered, the acetylcysteine or mucomist should be administered within 8 hours of acetaminophen ingestion. So from 8 hours from the toxicity when it happened. The IV form is available, but has certain or specific indication. Now, there is a loading dose, the second dose, third dose, all the specifics, all these specifics will be discussed in advanced or courses like Adult Health 3 course. Acetaminophen, in terms of interactions, is that acetaminophen should not be administered with alcohol or to patients who consume alcohol with the regular, because this greatly will increase the risk of liver failure. Even the alcohol-induced hepatotoxicity, it can occur at therapeutic doses of acetaminophen. So due to this additive hepatotoxic effect, acetaminophen should not be administered with other medications like barbiturates, carbamazepine, which is Tegretol, isoniazid, INH, Pharm. So because of that additive effect or risk on the liver to fail, so that's hepatotoxic effect, the acetaminophen should not be given with these medications, which like barbiturates, carbamazepine, isoniazid, Pharm,